Substance use during pregnancy, prevalence, impact, and solutions. This course is designed as an introduction to the complex issues related to prenatal substance abuse. It is intended to provide participants with a better understanding of the nature and prevalence of substance abuse among pregnant women in the United States and its impact on newborns and families. It also highlights some intervention models and policies developed to identify affected women and children and engage them in services to address their needs. Yet it is not intended as a comprehensive compendium of evidence-based practices. Policies and practices vary tremendously throughout the country, and there are far too many to adequately address in this forum. A complete reference list to accompany this training is available for download on the National AIA Resource Center's website at aia.berkeley.edu. Overview. The use of alcohol and other drugs during pregnancy is a significant health issue that affects both the physical and mental health of pregnant women. It is also a major risk factor for poor behavioral and developmental outcomes among children. In this presentation, we'll review the prevalence and nature of substance use among pregnant women in the United States, potential consequences of prenatal substance exposure for infant development and well-being, interventions for the prevention and treatment of drug use during pregnancy, interventions to promote the safety and well-being of affected newborns, and relevant policies. I'll begin with the prevalence of prenatal substance use. It's difficult to precisely gauge the prevalence of substance use among pregnant women. Impediments include underreporting by women, inconsistent use of screening or drug testing among providers, and inaccurate reporting systems. So data must be interpreted cautiously. With this caveat, the annual National Survey on Drug Use and Health shows that a small percentage of pregnant women use illicit drugs, with a greater but still relatively low percentage using tobacco and alcohol. These data further suggest that overall, pregnant women are much less likely to use substances than non-pregnant women of childbearing age, particularly for alcohol use. Also, as you can see from the graph, substance use tends to decrease considerably from the first trimester to the third trimester, but increase rather dramatically following childbirth. When looking specifically at illicit drugs, two patterns are worth noting. Pregnant teens are more likely to use illicit drugs than non-pregnant girls of this age. Also, regardless of age, Black women have a significantly higher rate of illicit drug use during pregnancy compared to white or Hispanic women. Many professionals in the field believe that these national data underestimate the total number of infants and families affected by prenatal substance use. In fact, prenatal screening studies suggest that as many as 1/5 of infants born in the United States each year are prenatally exposed to alcohol, tobacco, or other drugs, and the majority of them go undetected. Let's explore some of the factors contributing to substance use among pregnant women. Various socioeconomic, emotional, and psychological disadvantages contribute to alcohol or other drug use among women. Such stressors include domestic violence, a history of sexual or physical abuse, poverty, unemployment, and mental illness. One community-based study found that more than half of female drug users reported childhood sexual and/or physical abuse. Many of these women have experienced significant and often pervasive trauma. Separate studies have found that roughly half of married or cohabiting partners in treatment for substance abuse report recent episodes of domestic violence. In fact, the prevalence of substance abuse is higher among pregnant women experiencing domestic violence than among women reporting no current domestic violence. In this next section, I'll discuss the potential consequences of prenatal substance exposure for infant development and well-being. Despite considerable research on the subject, findings on the biological and developmental effects of prenatal drug exposure on children remain inconsistent. Determining the effects of prenatal substance exposure is difficult for a variety of reasons. Women who use drugs during pregnancy often use more than one substance, making it challenging to isolate the effects of any one drug. For instance, one study found that mothers who gave birth to infants exposed to illegal substances also used greater amounts of alcohol and tobacco while pregnant compared to mothers whose children were not drug exposed. Additionally, the amount of exposure, frequency of use, and timing of use during pregnancy may either moderate or exacerbate the impact of exposure on child outcomes. Determining the effects of prenatal substance use is also difficult because the biological effects of the substance is often combined with home and environmental deficiencies and poor utilization of prenatal care. For example, maternal substance use often leads to insensitivity when interacting with children, difficulty monitoring older children, and child maltreatment, which can all negatively affect child development. Moreover, mental illness and addiction may make it difficult for substance-using parents to form healthy attachments with their newborns and provide adequate parenting. Children of substance users also are more likely to be in out-of-home placements and experience home and caregiver instability. Conversely, caregiver functioning is positively related to the quality of the home environment, which in turn is positively related to executive functioning in drug-exposed children. Executive functioning is a concept used to describe a loosely defined collection of brain processes that are responsible for planning, cognitive flexibility, abstract thinking, rule acquisition, initiating appropriate actions and inhibiting inappropriate actions, and selecting relevant sensory information. While substance exposure alone may detrimentally impact child outcomes, some research suggests that the home environment has a greater impact on children than the biological effects of prenatal substance exposure. Despite these inherent difficulties in establishing the effects of prenatal drug exposure, researchers have identified patterns in outcomes of children prenatally exposed to certain drugs most commonly used by pregnant women. Let's take a look at some of these general findings, keeping in mind that all studies are subject to limitations that may influence the conclusions. Tobacco. Tobacco is the most common substance used by pregnant women with well-documented effects on the fetus. Adverse birth outcomes associated with tobacco use during pregnancy include miscarriage, low birth weight, shorter length, smaller head circumference, restricted fetal growth, respiratory infections, and asthma. Some research has also found lasting association between tobacco exposure and poor motor development. However, one study found that although tobacco exposure is a predictor of growth at age 1, it is not at any later age, suggesting that growth effects may not be lasting. Alcohol. Like tobacco, alcohol exposure consistently has been shown to have detrimental effects on the fetus. In fact, it is the most common preventable cause of birth defects and developmental disabilities, and no amount of alcohol exposure during pregnancy is considered safe. Fetal alcohol spectrum disorders, or FASD, encompass the range of effects that may result from prenatal exposure to alcohol. These include physical anomalies, neurobehavioral disorders, attention deficits, and cognitive disabilities. More specifically, problems associated with FASD may include abnormal facial features, poor coordination, poor reasoning and judgment, hyperactive behavior, learning disabilities, intellectual disability or low IQ, or problems with heart, kidney, or bones. Alcohol exposure may impact school performance, especially in mathematics, and it appears to affect academic achievement even after controlling for IQ. Alcohol exposure also may lead to insecure attachments between infants and mothers. However, alcohol-exposed children who had emotionally supportive mothers coped better with frustration and had higher levels of attachment security, which again points to the role of the home environment in determining the effects of substance exposure on child outcomes. Finally, children prenatally exposed to alcohol also have been found to be at an increased risk of developing an alcohol disorder in adulthood. Marijuana. Relative to other drugs, less research has been published on the impact of prenatal exposure to marijuana, and the findings are inconsistent. Prenatal exposure to marijuana has been linked to subtle increases in hyperactivity, impulsivity, inattention, delinquency, externalizing problems such as aggression and delinquency, and memory deficits. Furthermore, a recent study found that prenatal marijuana use impairs a baby's growth and development, with greater impairment the longer a woman uses marijuana during pregnancy. Additionally, like alcohol, marijuana may interfere with intellectual development and academic achievement. When other factors affecting intelligence were controlled for, one study found lower IQs in marijuana-exposed children compared to non-exposed children, and another found marijuana exposure to be linked to poor reading comprehension and underachievement in school. However, another study found that marijuana exposure does not impair IQ or basic visio-perception, but may influence the application of these skills in problem-solving situations. Cocaine. Due to the prevalence of crack cocaine use among pregnant women during the 1980s and 90s, many studies about its effects on infant development emerged. Some studies concluded that prenatal exposure to cocaine can have detrimental effects on child health and development, particularly in terms of attention, self-regulation, and language. Feeding problems have been observed among many exposed newborns. They often don't wake to feed and eat only small amounts at a time. These problems put the infant at risk for dehydration or malnutrition, which affect both physical growth and brain development. One study found that cocaine-exposed infants had twice the developmental delay during the first 2 years of life compared to non-exposed infants. Other research has linked cocaine exposure to poor motor development at ages 1 through 3 and motor skills deficits at age 7. Yet another study observed low motor skills in cocaine-exposed infants at 1 month of age, but with significant improvement over time. Similarly, growth may be restricted in infants exposed to cocaine, but prenatal cocaine exposure may actually be associated with elevated body weight in older children. With regard to academic achievement, one study found that children prenatally exposed to cocaine are more likely than non-exposed children to have an individualized education plan and receive support services in school. Prenatal cocaine exposure has also been linked to lower IQ scores, abnormal neurological exams, and deficits in visuospatial memory and speed. However, no significant difference has been seen in school achievement between children who were prenatally exposed to cocaine and those who were not, when environmental factors were controlled. In fact, home environment and caregiver characteristics appear to have a far greater impact than substance exposure on academic achievement. In the area of children's psychological attachment to their caregivers, evidence has also been mixed. The most important tenet of attachment theory is that a young child needs to develop a relationship with at least one primary caregiver for social and emotional development to occur normally. Although some scholars have found attachment problems among cocaine-exposed newborns, they were mediated by the temperament of the child, behavioral problems, and self-esteem of the caregiver. Overall, the research suggests that the effects of prenatal cocaine exposure on children are less significant than initially thought, and may be due more to the troubled environments in which many of these children are raised than the biological effects of the substance alone. Methamphetamine. The rates of methamphetamine use among pregnant women doubled between 1995 and 2007. Yet, unlike cocaine, relatively few studies have focused on the impact of prenatal exposure to meth on children. One study linked meth use during pregnancy to an increased likelihood of premature delivery, lower birth weights, and placental abruption. In addition, infants exposed to meth often have the same feeding problems seen in those exposed to cocaine. Brain abnormalities have been shown to be greater among children exposed to meth than those exposed to alcohol, including within structures involved in learning and memory. And children prenatally exposed to meth show lower scores than non-exposed children on motor integration tests. However, because the vast majority of women who use methamphetamine also use alcohol and/or nicotine, it's difficult to determine the specific effects of each substance. A recent exploratory study attempted to isolate the effects by comparing the outcomes of babies exposed to both meth and alcohol, those exposed to only one of these substances, and those exposed to no substances. The findings suggest that both alcohol and meth impair the part of the brain responsible for attention and verbal memory and learning, but that methamphetamine has a negative impact even beyond that of alcohol alone. Heroin. Heroin is an opiate that should be studied in conjunction with methadone, the drug used for the treatment of heroin-addicted individuals. An opiate is a drug derived from the poppy plant, hormone, or other chemical substance having sedative, narcotic effects, and pain-relieving effects. Infants born addicted to heroin, methadone, or any other opioid typically present characteristics of neonatal opiate abstinence syndrome, or NOAS. NOAS is associated with premature birth, lower birth weight, slightly depressed motor performance, and a tendency toward behavioral difficulties. Symptoms of NOAS appear within 24 to 72 hours after birth and characteristically include a high-pitched cry, tremors, and stiff limbs in an attempt to control the shaking. Over time, the infant may begin sweating, breathing rapidly, and experiencing gastrointestinal problems. It's important to note that stimulant drugs can mask opiate withdrawal symptoms. So an infant born addicted to an opiate, but also exposed to methamphetamine or cocaine, for example, may not show symptoms of neonatal opiate abstinence syndrome. Despite an increasing body of knowledge about the care of newborns exposed to opiates, few outcome studies exist on the longer-term impacts of opiate exposure. However, one of the largest samples observed longitudinally found that after controlling for birth weight and environmental risks, prenatal exposure to heroin and other opiates was not associated with mental, motor, or behavioral deficits through the first 3 years of age. Although subtle deficiencies in mental and psychomotor functioning were observed. Moreover, like with other illegal substances, studies suggest that the quality of the home environment plays a significant role in the developmental outcomes of opiate-exposed children. Prescription drugs. Psychotherapeutics is defined as the non-medical use of any prescription pain reliever, tranquilizer, stimulant, or sedative. Women are more likely than men to abuse prescription drugs and to be prescribed mood-altering drugs, which can also be abused. As the graph illustrates, fewer pregnant women use psychotherapeutics than alcohol, cigarettes, or marijuana, but psychotherapeutics are more commonly used among this population than cocaine and heroin combined. Prescription pain relievers, such as OxyContin, are the most commonly abused psychotherapeutic. Although few studies have examined the impact of prescription drug abuse on fetal development, the pregnancies of women using opioid pain relievers are often associated with a host of medical problems, including an elevated risk for obstetric complications such as premature birth, stroke, and drug withdrawal. Next, let's look at the societal impacts of prenatal substance exposure. Prenatal substance exposure is associated with significant societal and financial costs. For instance, neonatal hospital costs for children exposed to cocaine in utero are estimated to be significantly more than the hospital costs for non-exposed infants. Unfortunately, many women who give birth to substance-exposed newborns lack insurance, so the costs must be absorbed by the hospital. If the woman is covered by Medicaid, the costs become the responsibility of the state and federal government. Prenatal substance use also has been associated with child neglect, displacement, and family dissolution. Consequently, the need for foster care services is likely to increase for children prenatally exposed to substances, thereby burdening the social service system with additional court hearings, case management demands, costs associated with out-of-home residential placement, and the need for child welfare services. Finally, whether resulting from prenatal exposure or home environment, many children prenatally exposed to legal or illegal drugs require ongoing, costly intervention to address developmental, behavioral, academic, and socio-emotional challenges. Let's talk about interventions needed for the prevention and treatment of perinatal substance use. The National Center on Substance Abuse and Child Welfare has identified 5 intervention points for addressing prenatal substance use: pre-pregnancy, prenatal, screening at birth, services to infants, and services to parents. Similarly, Dr. Barry Lester has suggested a 3-tiered model of primary, secondary, and tertiary prevention. Specifically, primary prevention involves educating women about the harmful effects of substance use in pregnancy and treating substance abuse before conception. Secondary prevention includes identifying pregnant substance users and aiming to minimize the use of drugs during pregnancy. And tertiary prevention aims to lessen the consequences of children exposed to drugs. Let's review these points of intervention. Identifying and educating pregnant substance users. Interventions during pregnancy and interconceptually, that is, between a birth and a subsequent pregnancy, should include improving public awareness of the harm substances can do to fetuses. Pregnant substance users may also benefit from outreach efforts from family and friends, medical staff, and the media, informing them about overall health issues, as well as the dangers of prenatal substance use. Counseling and drug treatment should be emphasized prior to pregnancy, as substance use in the preconception period predicts substance use during the prenatal period. Creating a safe and welcoming atmosphere in the prenatal clinic also may be important in providing adequate medical care and retaining women in treatment during pregnancy. Even if a woman continues to use, prenatal care can help to improve the health of the woman and therefore her unborn child. In fact, every clinic visit provides an opportunity to screen a woman for substance use. Both the American College of Obstetricians and Gynecologists and the American Medical Association endorse universal screening of all pregnant women for at-risk drinking and illicit drug use. Numerous screening tools have been developed, including the 4Ps Plus, the 5Ps, the TACE, and others. All include a few simple questions about past and present substance use, and they take only a few minutes to administer. If presented in a non-judgmental, empathetic way, these tools can lead to brief interventions, which both encourage and educate clients. Motivational interviewing techniques also can be employed to determine where a client is in her recovery process and help her progress toward sobriety and stability. Motivational interviewing is a focused, goal-oriented, client-centered method for eliciting behavior change by helping clients explore and resolve ambivalence. Additionally, recognizing that some women do not access prenatal care for a variety of reasons, aggressive outreach by trained community members may help to engage pregnant substance users and break down barriers to needed services. These screening and outreach approaches assume that treatment services are available and accessible for pregnant women. However, a substantial majority of the estimated 6 million women who need treatment for a substance use problem each year do not receive it. Reasons for the lack of treatment include not being ready to stop using, financial constraints, and an inability to afford treatment, family and work obligations, a substance-using or violent partner, concern about the social stigma attached to disclosing the disorder and receiving treatment, and concern about prosecution and potential removal of their children. Even women who are ready to enter treatment may not have any available to them. Fewer than half of the states have either created or funded drug treatment programs specifically targeted to pregnant women. Although some states provide pregnant women with priority access to state-funded drug treatment programs and/or prohibit publicly funded drug treatment programs from discriminating against pregnant women, available programs are not necessarily accessible or sensitive to the needs of pregnant or parenting women. In fact, many facilities that accept women do not have any programs or groups specifically for women, and relatively few of the facilities that have gender-specific programs or groups for women serve pregnant women. Services needed for pregnant or parenting substance users. The Substance Abuse and Mental Health Services Administration, referred to as SAMHSA, identified the following 5 key programmatic considerations when working with families affected by perinatal substance abuse. First, cultural and racial concerns must be considered in every aspect of the treatment process. Second, treatment should be family-centered and include fathers to the fullest extent feasible. Third, community coordination and collaboration can help bridge gaps in available resources. Fourth, interdisciplinary training is essential. And fifth, problems of drug-exposed infants are present in communities throughout the United States and cut across all income levels. SAMHSA further notes that a comprehensive model for treating substance-using women and their newborns should include health, mental health, and social service components, as well as educational, vocational, and employment services. Successful approaches should include more traditional programs such as individual, group, and family counseling, child care, and domestic violence services, as well as parent education and medical care. Services should be available in the home and the community, and they must be gender-specific, relationship-based, and trauma-informed. Gender-specific treatment. Traditionally, substance abuse treatment programming has been geared toward males, without regard for the specific needs of women. Yet increased research on gender differences in substance abuse highlights the importance of gender-specific programs. Many substance-using women are in relationships with drug-abusing and often violent partners or spouses, and they are more likely than men to consider this relationship to be the cause of their drug abuse. Also, given the prevalence of physical or sexual abuse among substance-using women, treatment must address these issues in an environment in which women feel comfortable sharing. And research suggests that benefits from group therapy are better maintained when women participate in women-only groups compared to mixed-gender groups. Additionally, providers who work with substance-using women consistently point to stable, nurturing relationships with peer workers, professional case managers, or others as key to supporting women. Building upon this, the recovery coach model is emerging as a promising approach to serving substance-using pregnant women. A recovery coach is a paraprofessional who assists parents in obtaining needed benefits, coordinates child welfare and substance abuse treatment staff, and connects the family with treatment providers. Coaches often participate in joint home visits with child welfare workers or substance abuse treatment staff, but are independent from these agencies, ensuring that their focus remains on the family. As illustrated in the graph, evaluations have found that the use of recovery coaches significantly decreases the risk of substance exposure at birth. Treatment for co-occurring disorders. The fact that mental illness so often co-occurs with substance use disorders in women also necessitates the development of effective treatment programs to address both disorders. Several models currently exist to address the treatment of co-occurring disorders in pregnant and parenting women. In the serial model, substance abuse is addressed first, and then the client moves on to traditional psychotherapy. This model, however, might be ineffective given the high substance abuse relapse rate among addicts and those with severe psychiatric disorders. In the parallel model, treatment for psychological problems and addiction are delivered at the same time but in different milieus. This method allows for close collaboration between agencies, but may still not be coordinated enough for clients with acute mental disorders. The third, integrated model is recommended for clients with severe or pervasive psychological illness. This treatment model brings together addiction therapy and psychological therapy for an intensely integrated treatment plan. Because many women suffering from co-occurring disorders also have a history of trauma, treatment may be most effective if it is also trauma-informed. Unfortunately, current delivery systems often fail to screen for trauma and address it in treatment. Furthermore, they tend to be poorly integrated and focus on the client's immediate safety rather than long-term recovery from the trauma and co-occurring disorders. Recognizing the inadequacy of treatment for women with co-occurring disorders and histories of trauma, SAMHSA identified the following 4 core principles to inform best practices with this population. 1. Organizations and services must be integrated. 2. Settings and services must be trauma-informed. 3. Consumers, survivors, or recovering persons must be integrated into the design and provision of services. And 4. A comprehensive array of services must be made available. Implementing these elements may take time, additional staff training and support, and the collaboration of various organizations. But the result will be a service delivery system better equipped to meet the needs of women with co-occurring disorders and trauma histories. Harm reduction. While still controversial in some circles, harm reduction is gaining acceptance and popularity as an approach for working with prenatal drug use. This approach recognizes the attempts made by pregnant women to limit their drug use in order to promote the health of their pregnancy, even if they are unable to abstain from drugs completely. Acknowledgement of these healthy behaviors is often an important component in substance abuse treatment and prenatal care, particularly if it encourages women to continue receiving care. Now I'm going to talk about interventions to promote the safety and well-being of newborns. Ideally, to promote the safety and well-being of newborns prenatally exposed to alcohol or other drugs, services must address the unique needs of pregnant and parenting women, along with their infants, older children, partners, and other family members. Since 1990, the Children's Bureau has provided grant funding under the Abandoned Infants Assistance, or AIA, program to support comprehensive service projects working with families affected by substance abuse and HIV. The oldest federal agency for children within the Administration for Children and Families, the Children's Bureau has primary responsibility for administering federal child welfare programs and works with state and local agencies to develop programs to protect children from abuse and find permanent placements for those who cannot safely return home. AIA projects focus on serving the unique needs of each family, recognizing the important role that the family and social environment play in a child's outcome. A cross-site evaluation of AIA projects revealed improvements in the safety and well-being of participating children. Among the gains noted were a reduction in hospital stays, positive birth outcomes, and improved parenting, particularly if services were offered prenatally. Residential treatment programs for women and their children is one method of concurrently addressing the needs of both substance-using mothers and their children. These programs have higher retention rates compared to traditional treatment centers, which may be because mothers are not separated from their children, and the children are also involved in the treatment process. Such programs are often geared toward promoting the parent-child relationship. For example, they can involve teaching hands-on parenting skills to substance users, which may bring stability into the lives of their at-risk children, including both the newborn and older children. Furthermore, residential treatment programs for pregnant women have been shown to lead to better birth outcomes in terms of infant death, premature delivery, and low birth weight. They also are associated with increased social support and coping abilities among women participants. Shared family care. Shared family care is another promising model for simultaneously addressing the needs of substance-using women and their children. Shared family care refers to a situation in which an entire family is temporarily placed in the home of a host family who serves as a mentor and provides support. The host family works closely with a case manager who assists the mother in developing skills and supports necessary to care for her child or children and move toward independent living. A study of one program found that mothers completing a shared family care placement had increased sobriety and stability, as well as improvement in parenting skills, family interactions, child well-being, and family safety. Intervention for newborns. After birth, many substance-exposed newborns need special care. Infants who are exposed to heroin or other opioids often need to be closely monitored and weaned from their dependence. This may require careful administration of a narcotic drug, such as neonatal morphine or buprenorphine, to help comfort the baby, prevent seizures, and promote optimal weight gain and development. Newborns who do not require medical care typically go home with a parent or to a foster home. However, immediate and ongoing interventions often are indicated to assist parents in dealing with babies who may have difficulty feeding or regulating their states, or be inconsolable, hyperirritable, or hypertonic, for instance. Home-based interventions after birth have been associated with fewer behavioral and emotional problems, better developmental outcomes, and decreased levels of parenting stress. One successful home-based nursing program reported significantly fewer internalizing and externalizing behaviors among infants in comparison to children who did not complete the intervention. Nurses monitored the infant's health and growth, provided support and developmental guidance to mothers and caregivers, and promoted physical contact between the mother and child. Other home visiting programs have seen higher scores on cognitive and motor developmental measures in children utilizing home-based services compared to control groups not receiving services. Early intervention services may also enhance child development, and early case management services may increase positive affect among caregivers during parent-child interactions. Intervening early has been shown to have positive effects on many outcomes, including children's cognitive development and school readiness. Additionally, the AIA cross-site evaluation found that infants and families who received child-related services, such as infant and child developmental screening, assessment, and services, were more likely to be placed with their biological mother at program completion than infants who did not receive such services. One promising early intervention model specifically designed to address the speech and language problems associated with substance exposure is Enhanced Milieu Training, or EMT. This training supports responsive interaction between caregiver and child using verbal prompts, social consequences, and expansions of utterances. The verbal richness and adult sensitivity provided to at-risk children through EMT has been shown to be positively related to language abilities at 36 months. This finding suggests that early intervention techniques like EMT are critical to overcome developmental delays caused by substance exposure. Family treatment drug courts. Families affected by substance abuse may also benefit from family treatment drug courts, or FTDCs, which, unlike standard courts, are tailored to the needs of substance-abusing parents. Like adult drug courts, FTDCs include regular court hearings, judicial monitoring, drug testing and treatment, and regular monitoring of performance with predictable rewards and sanctions. However, there are several differences between adult drug courts and FTDCs. For example, while most of those served in adult drug courts are male, the majority of those served by FTDCs are female. Furthermore, the primary focus of FTDCs is family reunification, rather than avoidance of jail time, as is the case in adult drug courts. Family treatment drug courts offer services addressing the needs of the entire family, which often includes older children, and may also involve multiple parents, grandparents, and other relatives. Services generally are in the form of case management, drug and alcohol assessment and treatment, education, parenting support, and domestic violence services. FTDCs also form partnerships with medical and social service providers in the community to help connect families to the other services they need. These partnerships allow court case processing, child welfare services, substance abuse treatment, and other services to be integrated and coordinated for families. Overall, family treatment drug courts have been found to effectively serve families affected by substance abuse. A 4-year study of FTDCs found that they are more successful in helping substance-abusing women complete treatment and reunify with their children than traditional child welfare case processing. FTDC children also spend less time in out-of-home care than children in traditional courts. Involving fathers. Increasingly, FTDCs are attempting to address the needs of fathers. However, too often, interventions addressing the needs of substance-exposed newborns and families neglect the role of fathers, despite the fact that fathers are present in the lives of many substance-exposed newborns. Even if the father lives with the mother and child, or is also a drug user, most treatment programs exclude him. Many providers fail to outreach to the father, especially if he is viewed as violent, absent, or uninvested. Fathers may be discouraged from involvement with their families by feelings of inadequacy that can emerge from a failure to meet society's high standards for fathering. However, even if a woman has left her partner, he still is important to the child and can benefit from parenting support and involvement in his child's care. If he is a drug user, it is important that he also receive substance abuse treatment. Children of substance-using fathers witness more parental conflict and violence, and experience more anxiety and depression than children of fathers who do not abuse substances. Even if the substance-abusing father does not live with the family, his child is more likely than children of non-using fathers to have poorer health and behavior problems. Thus, engaging fathers in treatment and managing parental conflict are key to preventing child maladjustment. Substance-exposed children may be best served by comprehensive programs that involve their entire families, fathers included. Additionally, a few programs designed specifically for substance-using fathers are beginning to emerge. These programs recognize the important role that fathers, custodial or not, play in a child's life, as well as the reciprocal relationship between abstinence and good parenting. More programs like this are needed in order to improve treatment outcomes for pregnant and parenting women and improve the well-being of their children. Now I'm going to move away from program models and review state and federal policies relevant to prenatal substance abuse. Many state laws and policies have been established in an attempt to prevent and address prenatal substance use. Numerous states include prenatal substance abuse in their child maltreatment laws, and a few authorize forced admission to treatment for pregnant substance users. Additionally, a number of states require healthcare professionals to report prenatal drug exposure, and several require them to test for substance exposure if they suspect abuse. Approximately half of the states have statutes intended to make drug treatment more readily available to pregnant women through priority access, the creation of targeted programs, and/or by prohibiting treatment programs to discriminate against pregnant women. Some state policies are more punitive, focusing primarily on the safety of the child, whereas others are more preventative, considering the health and well-being of the woman and her newborn. Through agency policies and allocation of state funds, the more health-oriented approaches emphasize screening during pregnancy and collaborative approaches to address the needs of substance-using pregnant women. For example, Virginia has legislation requiring universal screening of all pregnant women. And Washington State developed guidelines highlighting the importance of and strongly encouraging universal screening, as well as open, ongoing relationships between patients and providers. Through legislative mandate and/or funding appropriations, Washington State also operates 2 programs to provide early intervention and other services to pregnant women and their young children. Other states have imposed tobacco and/or alcohol taxes to help fund similar services. Until recently, no federal policy related to perinatal substance use existed. The Keeping Children and Families Safe Act of 2003 reauthorized the Federal Child Abuse Prevention and Treatment Act, or CAPTA, requiring states receiving CAPTA grants to comply with the following provisions. They must provide assurances that medical staff notify Child Protective Services, or CPS, of infants identified at birth as affected by prenatal exposure to illegal drugs, and that they will develop policies and procedures to address the needs of substance-exposed infants and develop plans of safe care for affected infants. The law allows states considerable discretion in determining how the provisions are implemented. For instance, it does not establish a federal definition of child abuse or neglect, although it clearly states that notification should not be construed to require prosecution for any illegal action. Additionally, state, local, and agency policies determine how substance-exposed newborns are identified, whether or not an official CPS report is required when referring drug-exposed infants, and the level and type of proof needed to warrant further investigation. On all of these issues, policies vary widely among and even within states. For instance, some hospitals conduct toxicology tests on all pregnant women and/or newborns, whereas most develop protocols for determining who gets tested. Similarly, some Child Protective Services agencies require a positive toxicology test on a newborn to open a case, while others might accept a positive test on just the mother or verbal admission of use. And some hospitals and child welfare agencies give differential treatment for various drugs. For example, a newborn exposed only to marijuana may be treated differently than one exposed to cocaine. And few child welfare policies even address exposure to alcohol or prescription drugs, which were similarly omitted in the CAPTA legislation. The Child Welfare Information Gateway has a regularly updated, searchable database of state child welfare laws that address parental alcohol or other drug use in their child maltreatment definitions. Conclusion. Overall, drug use during pregnancy poses multiple risks to children and families, including the mothers and fathers who continue to use. The physiological effects of drugs, their impact on the quality of the home environment, and associated psychosocial stressors all may harm affected children and families. Nonetheless, no consensus has been reached about the extent to which prenatal drug exposure impairs child outcomes. Further research is necessary to understand the short and long-term effects of prenatal drug use, and to tease out the differential effects of prenatal exposure and environment, so that more effective interventions may be developed. In addition, comprehensive evaluations are needed to better estimate the scope of this problem across racial and socioeconomic groups. A better understanding of the effects of substance exposure on infants will also drive policies guiding the treatment of substance-abusing pregnant women and their newborns. Policies that support early identification of pregnant substance users and early intervention services for substance-exposed children appear to be particularly helpful at improving birth and developmental outcomes. Yet, continued program evaluation and research are needed to establish the effectiveness of policies and interventions, and to determine best practices for assisting women and children impacted by perinatal substance use. For more information about prenatal substance use and substance-exposed newborns, please visit the National AIA Resource Center's website at aia.berkeley.edu.